I want to welcome you to our event today on the status of the Affordable Care Act. A number of people may be joining us online, so if you fall asleep, you may find yourself on TV. That's a fair warning. But I'm sure you won't, because Louise is going to keep it lively. The Affordable Care Act, as many of you know, was passed in March 2010 with the primary goal of expanding the number of Americans with health insurance, partly through expanding Medicaid and partly through creating marketplaces or exchanges for people to buy individual policies, people who don't have insurance through work or through government programs. And in order to make the policies affordable, a set of subsidies was put in place. Although the ACA actually embraced some ideas that had come from Republicans, our own Stuart Butler, formerly of the Heritage Foundation, now here, had been involved in some early designs. It was partisan right from the start, and Republicans have begun to dismantle parts of it, particularly by repealing the individual mandate and relaxing some of the standards on policies that insurance companies can offer. Now, I'm pretty much convinced that many Americans don't have a clue what the ACA is. Some of them probably think it has been fully repealed. For what it's worth, the latest Pew Research survey in December found for the first time more Americans said the ACA had a positive effect than a negative effect, although when you look beneath the numbers, it was very partisan. Seems if you're a Democrat, you think it was great for America, and if you're a Republican, you don't. Interestingly, that half the people said the ACA hadn't had much effect on their families, and of those who said it had had an effect, they're evenly split between people who said it was positive and negative. So our attempt today is to shed some light, some facts, some dispassionate analysis on the controversy over the ACA, and particularly the status of the individual markets. The ACA may be wounded, but it is not dead. About 16 million Americans are buying individual insurance policies today, more than half of them on the exchanges. And that's what we're here to learn more about. What is the state of the market for individual health insurance? What has transpired in that marketplace since Congress and the Trump administration began to try and roll it back? And where are we going? A moment about the plan for the program. We're going to start with a presentation by my colleague Matthew Fiedler. Matt is a fellow here in the Center for Health Policy. Before he joined Brookings in the beginning of 2017, he was at the Council of Economic Advisors as the chief economist, where he worked a lot on health policy issues. Matt has a PhD in economics from Harvard and a BA in math and economics from Swarthmore. After his presentation, we'll have some slides, and they'll be on their website if they're not already. My colleague Louise Shaner will moderate a panel. She'll introduce the individuals later, but it includes a health insurance company CEO, the head of a state exchange, and 3 researchers with expertise but different viewpoints on the state of the individual market. I do want to note that we invited a Trump administration official to participate, and unfortunately he declined, so they are here in absentia. Again, remember this is being webcast, and if you feel the urge to tweet about it, the hashtag is the future of the ACA. Matt.
So thanks, David. In the 15 minutes before we get to the panel, my goal is to just provide some sort of baseline facts and an overview of what's happening in the market and where we're potentially headed. So a quick view of, do a quick refresher on what the ACA did and where that left the individual market as we entered 2017, what the Trump administration has changed since the beginning of 2017, and what that's likely to mean for the future of the market. So just as a quick refresher, what did the ACA do? David did a little bit of this, but one of the main goals of the ACA was to expand insurance coverage. Did that in 2 main ways. One was giving states the option to expand their Medicaid programs to more low-income adults. The main focus today will be the ACA's changes to the individual market, which had 3 main pieces: a set of regulatory changes barring insurers from denying coverage or varying coverage terms based on health status, and a requirement that insurance plans on the individual market meet various benefit standards, both with respect to what they cover and cost sharing. Subsidies to reduce premiums and cost sharing for low and moderate income people, and then, of course, the ACA included an individual mandate. The combined effect of these various policies was to sharply reduce the number of people without health insurance in the United States after 2013, and by 2016, the share of people without health insurance had fallen to about 9%. About 1/3 of that overall increase in insurance coverage after 2013 can be accounted for by an increase in enrollment in the individual market. Individual market enrollment rose from around 11 million people pre-ACA to somewhat more than 17 million people by 2015 and 2016. Now, while enrollment in the individual market had expanded considerably, by 2016, we also know that the market had clearly not fully adjusted to the changes in the institutional environment made by the ACA by 2016. As we entered 2017, we saw substantial increases in individual market premiums, averaging more than 20% nationwide. We also saw a significant number of insurers withdraw from the individual market, as reflected in the light blue line here, showing that the number of enrollees who had 3 or more plans to choose from fell from about more than 80% in 2016 to less than 60% by 2017. So what was going on? I think the main driver of the disruption we saw from 2016 into 2017 was that this was not a profitable business for insurers over the first few years in which it was in existence. As you can see from comparing the dark blue line, which shows insurers' total per enrollee costs, to the darker green line that shows their total per enrollee revenue, insurers were incurring losses on average nationwide of probably about 6% in 2014 and broadly on the order of 10% of revenue in 2015 and 2016. So what was going on here? I think it's not terribly surprising that insurers would have incurred some losses in the early years of the new market. The various reforms that the ACA put in place changed substantially who was in the individual market, both in terms of their health status mix, but also in terms of their income mix. Predicting what average claims cost was potentially challenging, and so it's not necessarily surprising that insurers would miss to some degree in one direction or the other. Whatever the reason for why these losses were incurred over the first few years of the market, we saw that substantial pricing correction in 2017. We don't yet have complete data for 2017, but based on the fragmentary data we do have, my best estimate is insurers were probably break even or slightly profitable on average in the ACA compliant market during 2017, reflecting that sharp increase in premium revenue and relatively subdued growth in claims costs. Now, that slow growth in claims costs during 2017 may be somewhat surprising in light of the stories that we were hearing from 2016 into 2017. You'll remember that there were concerns that the increases in premiums would cause large reductions in individual market enrollment, particularly among healthy people, so average per enrollee claims costs in the market would rise substantially. That didn't happen, and I think it's instructive to think a little bit about why that didn't happen. I think the most important factor is that about 3/5 of enrollees in the individual market writ large receive tax credits under the ACA. Those tax credits are structured so that when premiums rise, the tax credit rises dollar for dollar, and so enrollees' net premiums don't change. For the other 4/5 of the market, the data we have indicate there has been some attrition during 2017. But at least from what we would have expected based on prior evidence, and it seems broadly consistent with the data we have to date, that attrition has not been nearly severe enough that it would have caused a large increase in average claims costs in the individual market. Indeed, if you put together sort of everything we know about how many people are subsidized and how responsive we would have expected the unsubsidized population to be to higher premiums, we would only have expected that premium change to create maybe 1% to 2% of upward pressure on average claims costs in the individual market. So the bottom line is, by the time we got to 2017, it looked like insurers had found a roughly sustainable price point in the individual market. Probably varied from geography to geography and insurer to insurer whether, in fact, they had found that price point. But the market as a whole was in the ballpark and headed towards an equilibrium. They're obviously, on the road to that equilibrium, we have seen some substantial policy changes since the beginning of 2017. And so over the rest of my talk, that's what I want to focus on. I'm going to focus on 3. The Trump administration's decision to end cost-sharing reduction payments, the repeal of the individual mandate in the tax legislation enacted at the end of last year, and the Trump administration's recent proposal to expand short-term plans. I want to be clear that these are not the only 3 policy changes towards the individual market that have happened since the Trump administration took office, but they are the 3 that I think are going to have the largest impacts. So in our limited time, they're the 3 I want to focus on. So starting with the end of CSR payments, just a quick refresher on the structure of the cost sharing reduction or CSR program. Insurers under the ACA are legally required to reduce cost sharing for people with incomes below 250% of the poverty line who purchase silver plans on the marketplace. So that's through healthcare.gov or through a state-based exchange rather than directly from an insurer. The federal government is then required to compensate insurers for the cost of providing that reduced cost sharing. Those payments were occurring until the Trump administration ended them in October of 2017, citing a lack of appropriations authority. Now, with those cost sharing reduction payments gone, the cost to an insurer of offering a silver plan is now substantially higher. And so insurers' incentive is to raise premiums for those silver plans, but not necessarily for other plan types where cost sharing reduction payments were not previously available. In most states, insurance regulators permitted this approach of so-called silver loading, raising prices only for silver plans, or in many cases actively coordinated that outcome. The upshot is that in about roughly 9 in 10 enrollees live in states where all insurers pursued this type of silver loading strategy, and about 7 in 10 enrollees are in states where premiums only rose for on-marketplace silver plans. Again, those purchased through the exchange rather than directly from an insurer. This silver loading strategy has had some counterintuitive effects. So recall that the structure of the tax credit on the ACA is that it's based on the cost of the second lowest cost silver or benchmark plan. So when silver premiums rose, that meant the tax credit rose dollar for dollar. If you're in a silver plan and eligible for subsidies, that meant that this was roughly a wash for you. Your premium rose, but your tax credit rose. But if you were in a bronze or a gold plan, your bronze or gold premiums didn't rise because of the cost sharing reduction cutoff in most states. But the tax credit still rose along with the silver premium. So premiums for bronze and gold plans for consumers eligible for subsidies often fell. That created 2 groups of winners. First was people who were buying bronze and gold plans before, but a second group of potential winners are people in silver plans with incomes between 200 and 400% of the poverty line. Because bronze and gold plans are now cheaper, they potentially have the option to switch out of a silver plan they may be purchasing now towards a bronze or a gold plan, and potentially get a better deal as a result. The number of people in these 2 categories is fairly substantial. So around 1 in 3 marketplace enrollees are either in that we're already buying bronze and gold in 2017, or are in a silver plan with incomes between 200 and 400% of the poverty line. On the other hand, unsubsidized enrollees are largely, though not entirely, unaffected. Most unsubsidized enrollees are either purchasing coverage outside the marketplace directly from an insurer, or they're purchasing non-silver plans. So in states where premiums only rose for on-marketplace silver plans, they're just immediately unaffected. Many other silver plan enrollees, even if they're purchasing an on-marketplace silver plan, they had the option to switch and purchase an off-marketplace silver plan, in many cases a very similar plan from the same issuer. So this transition involves some significant hassle costs for them, but at least in most states didn't necessarily substantially reduce their actual coverage options. Now, the flip side of the fact that subsidized enrollees are doing better is that the federal government is going to spend more. There's no magic here. In most cases, if you want to improve affordability for consumers, somebody else is going to be paying more for that. So there's a certain irony in the outcome here. I don't think the Trump administration, when it ended cost-sharing reduction payments, was aiming to increase affordability for some subsidized consumers by spending more, but that's the outcome. The flip side of that is, I think, many Democrats who were potentially interested in spending more on subsidies in order to increase affordability can be reasonably happy with this outcome. The individual mandate. So the individual mandate will go away effective at the start of 2019 as a result of the tax legislation enacted at the end of last year. As a qualitative matter, we have a pretty good sense of what the effects of this will be. Some people will drop their coverage, and we expect the people who drop their coverage to be healthier than average. In terms of how we should think about that, I think we can think about 2 groups of people. One is the people dropping coverage themselves. Those people are making a judgment that they perceive the benefits of insurance coverage to be lower than the cost of that coverage, so they're at least potentially better off. Now, that argument assumes that that weighing of costs and benefits is fully rational. And I think particularly in the context of health insurance, there's some reason to question whether in fact decisions in that area are fully rational. But at least in principle, these people could be winners. The flip side of that, though, is other people in the healthcare system. When healthier people leave the individual market, premiums in the individual market have to rise. So if you're somebody who's still purchasing coverage in the individual market and purchasing that coverage without a subsidy, these are generally sicker people on average, you're going to pay more for that coverage. Likewise, some of the people who drop coverage are still going to get sick. They are going to show up and they're going to show up at hospitals and in many cases still receive care but not be able to pay for that care. So some of the incidents of those individuals' decision to drop coverage will end up on healthcare providers. In terms of the precise magnitude of the removal of the mandate, I think that's considerably more uncertain. CBO's estimate was that 13 million fewer people in the aggregate would be covered in the long run as a result of repeal of the mandate. About 5 million of those people are coming out of the individual market, resulting in about a 10% premium increase in the individual market. Surveys where you ask people, what do you plan to do if the individual mandate went away, generally suggest somewhat smaller effects, but still meaningful effects on insurance coverage. Just one other piece of evidence that leads me to believe that the repeal of the mandate will indeed have a meaningful effect on the number of people with coverage is the fact that the uninsured rate dropped fairly sharply among people with incomes above 400% of the poverty line from 2013 through 2016. So remember that these people were not eligible for the ACA subsidies, so that can't be driving the increase in insurance coverage in this group. Rather, I think there are a few potential explanations, but I think the most plausible explanation is that the mandate was affecting coverage decisions in this group. That leads me to believe that both in this group and other income groups, repeal of the mandate is likely to lead some number of people to drop out of the insurance market. So just as the final policy I want to touch on is the Trump administration's rule expanding the availability of short-term plans. So these so-called short-term limited duration plans, the reason they matter is that they're exempt from all insurance market regulations implemented by the ACA. They can vary premiums based on health status. They can deny coverage based on health status. They don't have to cover the essential health benefits, and they don't have to provide the various protections against cost sharing that ACA plans are required to provide. Given how different the regulatory environment for these plans are, it's really important what the definition of a short-term limited duration plan is. That term was actually never defined in statute, and so it's been defined in regulation. The current rule is that a short-term limited duration plan is a plan that lasts no more than 3 months and can't be renewed. The Trump administration's new proposal is that a short-term limited duration plan could be a plan that lasts no more than 12 months with a possibility of renewal. This is a fairly expansive definition, so I think what we're really talking about if the Trump administration proposal goes forward is creating a full parallel non-compliant market. We can think about that having a few different types of effects. For many healthier enrollees, these short-term plans are going to look more attractive because they can be offered a premium that's consistent with their better health status. They'll often pay a lower premium. And if they're not eligible for a large subsidy, that means they're likely to leave the ACA-compliant market and shift into these short-term plans. That will raise premiums in the compliant market, raising costs for unsubsidized enrollees who remain in the market and potentially raising costs for the federal government. It's also the case that these short-term plans will likely provide somewhat less comprehensive coverage on average, given the lack of the various regulatory requirements and the lack of risk adjustment in the short-term market. The flip side of that, and what many advocates for this policy, the case they make, is that because these plans are cheaper, they may lure some healthier individuals out of the uninsured population into short-term plans. How you're going to feel about this policy depends on how you trade off these costs of pulling people out of the compliant market against the potential benefits of pulling people out of the uninsured population. I tend to believe that the costs here are going to outweigh the benefits, but this is the basic trade-off. So just to wrap up, taking all of these policy changes together, what do we expect the market to look like going forward? The market will survive and will find a new equilibrium, and I think the most important reason for that is that you have a large population of individuals who are eligible for very generous subsidies that rise as premiums rise. So even as premiums rise and even with the availability of short-term plans, they're still going to find it attractive to remain in the ACA compliant market, and that will have a powerful stabilizing effect on the risk pool. That's not to say that it will be all rainbows and sunshine. I think forecasting exactly what the risk pool is likely to look like after these changes take effect is hard, and that's going to mean that pricing for this market is hard in various ways. That will probably lead to bumps along the way. So I think the bigger question is not will the market survive, but what will the new equilibrium of this market be, and how will it compare to the equilibrium that we were on our way to prior to these policy changes. At a high level, I think we're looking at fewer people covered, particularly adjusted for quality. So we're going to have some people in these short-term plans that may report being covered, but have less comprehensive coverage than they did before. We're likely to have less pooling of risk between healthier and sicker people. Both the removal of the mandate and the short-term plan rule will have the effect, in many cases, of shifting costs from healthier people onto sicker people. And then the final effect is that some subsidized enrollees, because of the end of CSR payments, will pay lower premiums. That will, in terms of overall effects on the market, partially offset, I think, some of the effects on the risk pool and enrollment that come from fewer people from the repeal of the mandate and the short-term plan rule, but will likely not be sufficient to do so. So with that overview, I look forward to the discussion.